and it will be made available for those who couldn't attend today. So again, I'm Dr. Nirav Shah. I'm the Senior Medical Director over Quality Improvement. I was at Kaiser for over 12 years, like Dr. Kasavu said, and I joined Regal about 3.5 years ago. Really, the aim of this talk is to help employees and staff understand the current monkeypox outbreak. In terms of today's agenda, we'll start with the history of monkeypox. We will then discuss the current outbreak. We'll talk about the signs and symptoms of monkeypox. We'll move to the transmission, prevention, and treatment. And at the end, we have some time available for question and answers. And again, if you also have questions that come up after this talk, please contact me or contact HR, and I'll be happy to try to answer those questions. So again, we're going to talk about monkeypox, the outbreak, signs, symptoms, transmission, prevention, and treatment. So let's start just about the history of monkeypox. It's really a rare disease caused by an infection with the monkeypox virus. It's the same family of viruses that causes smallpox and causes similar symptoms to smallpox. However, smallpox has a 30% mortality, whereas death due to monkeypox is exceedingly rare, which is good. Smallpox was eradicated in 1980, but due to the concern that it could be used as an agent of bioterrorism, it continues to be well studied. Additionally, we've developed diagnostic testing, vaccines, and therapeutics for smallpox. The smallpox vaccines and therapeutics can be used for monkeypox since they're in the same family of viruses. So this is a really important point. Unlike COVID, we do know quite a bit about monkeypox just because it's a close relative of smallpox. So smallpox was initially discovered in 1958 when there were 2 outbreaks of a pox-like disease occurring in colonies of monkeys kept for research. The first human case of monkeypox was recorded in 1970. Before the current outbreak, all monkeypox cases outside of Africa were linked to international travel or to endemic countries through imported animals. So up to this point, monkeypox has really been a disease of Central and West Africa. There have been some outbreaks within those African countries and then outside, really due to travel or animal exportation. So again, this is the first real outbreak we've seen of monkeypox that's been outside of Africa and that's starting to travel through local virus transmission. So again, one of the key points that's really important is monkeypox has been well studied and we have therapeutics vaccines that are available. The monkeypox outbreak differs significantly from the current COVID pandemic that we've been experiencing. When we had the COVID pandemic, there was little known about the virus. We had no vaccines, therapeutics, or treatment. And so this is not the same in terms of infectiousness, in terms of how many people it's affecting, and then also what we know about the virus itself. Okay. Now I want to really spend a little time talking about the current monkeypox outbreak. The leading theory to explain why the current outbreak took place was that there were sexual transmission at 2 raids held in Spain and Belgium. Many individuals traveled to these events, contracted the disease, and then returned to their home countries. As of now, we have over 25,000 confirmed monkeypox cases worldwide, and we have over 7,000 cases in the US. We have about 800 cases in California. If you look at the graph on the slide, it shows that we're really seeing this logarithmic increase in monkeypox cases. But remember, we're still at 800 for total cases in California. To put this in perspective and comparing it to COVID, we've had 3.3 million cases of COVID in LA County, where we've only had 800 cases in all of California due to monkeypox. So since the outbreak has began, there have been different agencies that have looked at these cases of monkeypox. So they looked at the initial 3,400 cases in the US, and they noted that 99.1% were male, 99% were related to male sexual contact, 99% of the cases were related to close, intimate contact. Many initial patients reported international travel 21 days before symptom onset, participating in large festivals or other activities where close personal skin-to-skin contact likely occurred. We're now seeing an increased number of cases due to local transmission. So when the outbreak began, it was really from individuals who traveled and visited some of these raves in Europe. But now what we're seeing is those same people have come back, and we're starting to see local transmission of monkeypox. And that's really why we're concerned, and we want to really try to stop the spread of monkeypox before it becomes endemic in our country, basically. So from prior outbreaks, we know that monkeypox can be spread through direct contact with someone who has the rash, the scabies, or from their body fluid. Even though this is predominantly a disease that affects men who have sex with men at this point, it can spread to the general public. In prior monkeypox outbreaks, we have seen family members contract monkeypox through non-sexual transmission. The goal is to stop transmission before spreading the disease to the general population. As experts are concerned that if transmission is not stopped, it could become an endemic disease, okay? So the key point is monkeypox affects men who have men currently, but it can spread to the general public. If the disease does spread to the general public, it can become endemic, similar to what's happened in Central and West Africa, and it's a disease that we'll have to continue to deal with. So by declaring a public health emergency, it's allowing states and local officials to access resources, funding, to be more flexible and try to really fight the outbreak before it spreads to the general population or becomes endemic. So this is really the thought process by creating it as a public health emergency. It was initially California, New York, and Illinois, and now it's a US public health emergency. Okay. So now I want to kind of shift gears and really talk about the signs and symptoms of monkeypox. So early signs include fever, muscle aches, headaches, swollen lymph nodes, exhaustion, and sometimes cough or sore throat. The symptoms are consistent with a flu-like illness. Clinicians should be on high alert if patients have any of these symptoms, especially in men who have sex with men. Symptoms usually start within 6 to 13 days post-exposure, but can start up to 3 weeks post-exposure. After the flu-like illness, the rash usually develops in 1 to 4 days after symptom onset. The illness typically lasts 2 to 4 weeks. Patients are considered infectious until new skin forms on these lesions. This is critical. Individuals are infectious until new skin forms over all the lesions. Monkeypox can spread from symptom onset until all the lesions are healed and new skin has formed. The isolation period is much longer than COVID. It can be up to 28 days, and it's really determined by the skin findings. There's also an article that's been published in the New England Journal of Medicine, which looked at 500 initial individuals with monkeypox. So again, 98% are gay or bisexual. The rash was the presenting symptom for 95% of the patients, okay? 64% of the patients had less than 10 lesions. And we'll talk a little more about the lesions and the number in a little while. 41% had HIV, and so they were immunocompromised. In general, immunocompromised individuals are at a higher risk for developing more severe cases of monkeypox. In terms of those 500 individuals that were studied, 95% transmission was through sexual activity. 73% had anogenital lesions. So this is also creates a diagnostic challenge because you may not be able to see those lesions on physical exam because they may not be visible. 41% had mucosal lesions. So again, if they're in the anogenital area and they're mucosal, you may not be able to see them on standard physical exam. 9% only had one single lesion. So the rash consists of one lesion. So this wasn't the diffuse rash clinicians saw. When we first heard about this and we're looking at the CDC and WHO websites, most of the images we saw showed this diffuse rash similar to smallpox that we've seen for years. But in practice, most of the individuals had less than 10 and some only had one lesion to begin with. So again, additionally, in terms of the fever, only 62% had fever. A large percent of patients had no fever or lymphadenopathy. And the lack of adenopathy or fever really couldn't be used to rule out monkeypox. So when I initially started reading about monkeypox, I thought the adenopathy would be useful, the fever would be useful, but again, they're pretty nonspecific and they're not seen in a high enough percentage of the population that you can rule out the diagnosis just because they're not present. So this is really a challenge in terms of diagnosing monkeypox. One, it's a rare condition. It has some very nonspecific symptoms, and it has some pretty atypical or minor rash findings. So again, it's really important that we have an awareness and a really low threshold for testing. Again, this is how we're going to catch the disease and hopefully stop the spread of it. So in terms, I want to spend a little time about the rash itself. Again, I just said that the rash many times or most times isn't typical. I just want to go through what the rash is supposed to do, just to give you a framework. Again, remember that this is not going to be the majority of patients, but again, I think there's some utility in terms of going over it. So the rash is supposed to begin with an enthanum in the mouth. Then they're supposed to develop a macular rash on the face that spreads to the arms and the legs. One of the other important distinguishing factors about this rash is it affects the palms and the soles. And this is important because there's only a few other diseases that do that. So if you see a rash on the hands or the soles of the feet, think about monkeypox. Again, it could be other things as well, but it's one of the important distinguishing factors. One of the other important distinguishing factors is the lesions should all be in the same stage. So if they're macules, they should all be macules. If they're papules, they're all papules. If they're scabs, they're all scabs. Again, it's not 100%, but that's what it's supposed to do. And again, this is an important distinguishing factor because if you look at chickenpox has lesions in all stages. And remember, chickenpox, can be confused. But again, this is one of the important distinguishing factors. So remember, the two takeaway points is the rash affects the palms and the soles. This limits your differential diagnosis. Second, the lesion should be in the same stage. And remember, in chickenpox, they can be in all stages. So again, I added this more for reference than anyone else. We see macules, papules, followed by vesicles, then pustules, and finally crusts. Again, I added this for reference again to kind of go over what a macule is, a papule, a vesicle, a pustule, and a crust. Remember when these lesions open up, that's really one of the main areas or times you can spread the disease. You can spread it at any time, but the highest spread is if they're open lesions. So again, I want to spend a little more time talking about the rash. When the outbreak began, many clinicians were expecting these classic monkeypox rashes that would start on the face, spread to the arms and legs, and then finally the trunk. This is what the CDC and the World Health Organization had really posted on their website, and it's kind of what we were expecting. Our expectation when the outbreak began was to see a diffuse rash that affected a large percentage of our total body surface area. This is what I was expecting when I heard about monkeypox. In reality, we're seeing some very minor rashes. Most patients have less than 10 lesions. Many are in the anogenital area, so that's really where they get it from close intimate contact. Many may not be visible on the exam because they're on the mucosal surface. Many patients actually presented with pain. That was their initial symptom even before rash onset. So many patients had anal pain, and there was a delay in diagnosis monkeypox because there wasn't a rash. So again, it's an atypical rash. It may be preceded by pain. Again, we want clinicians and our clinical staff to really have a high index of suspicion and a low threshold to test patients. Again, the history is also important. So anyone who's gay or bisexual or transgender, additionally, if they've had anonymous unprotected sex, or if they've had known contacts with monkeypox, are really important to address and ask our members. Okay. In terms of testing, the rash can be confused with herpes, syphilis, and varicella. If you have someone with a rash that you're concerned with monkeypox, please put on all your personal protective equipment. That includes a mask, face shield, gloves, and gown. So again, if you're concerned about monkeypox, you're going to test someone for monkeypox, use a mask, face shield, gloves, and gown. Dispose of those properly to prevent spread of it. Most patients with monkeypox don't require admission. They can be sent home with follow-up on those test results. In terms of where we order the test can be ordered through Quest. They have an assay that's a real-time PCR. We want to use one of the viral swabs and swab the pustule or lesion vigorously. Place the swab in a viral culture medium or an equivalent tube. The recommendation is if you see a lesion that you're concerned about, especially if it's in the anogenital, to do 3 lesions and to send those to Quest. I'm always a resource if you have questions, and the Department of Public Health is also a great resource if you have questions or concerns about someone. Okay. We're going to talk a little about transmission because this is really important. We're getting a lot of questions about transmission and concerns about transmission. So the modes of monkeypox transmission are direct contact with a skin lesion. Additionally, direct contact with contaminated objects or fabric, and respiratory droplets or secretion are modes of transmission. So again, direct contact with a skin lesion, but also contaminated objects, fabric, respiratory droplets are known modes of transmission, okay? When we actually look at the current outbreak, the overwhelming majority are through intimate contact in men who have sex with other men and their social networks. So again, from prior outbreaks, we know it can be through other forms, but from this outbreak, the majority are through intimate contact. And this is an important point. This is why we're really trying to stop the spread, because we don't want it to spread into the general public. Okay. In terms of, there's a lot of concerns of transmission in a public setting. So in terms of transmission in public settings, they're extremely rare, from face-to-face interactions or touching a contaminated surface, okay? And the monkeypox non-sexual transmission rate in households where one of the persons has monkeypox. So if I lived with someone who has monkeypox, my risk of contracting it through a non-sexual transmission is 0.6%. So it's exceedingly low. So when we look at the risk of monkeypox in a public setting, it's exceedingly low. So again, I don't think we have to worry in terms of short face-to-face interactions, even contaminated surfaces. Overall, this is exceedingly rare. And I've gotten questions about older immunocompromised patients, what things they should do. Again, this is going to be exceedingly rare in a public setting. Okay. I want to switch gears and really talk about prevention of monkeypox infection. So things the CDC recommends to avoid the spread of monkeypox. It's obvious. Some of these are obvious, but obviously avoid oral, anal, vaginal sex, or touching the genitals or anus of anyone with monkeypox. Avoid hugging, massaging, kissing, or talking closely with someone with monkeypox. Avoid touching, sharing fabrics, surfaces, objects with someone with monkeypox. So again, try to avoid any contact with someone with monkeypox, but obviously no physical contact, and avoid sharing linens and objects, utensils, things like that. If you have personal contact with someone with monkeypox, to use personal protective equipment. So especially in the healthcare setting, if we're concerned about someone having monkeypox, use PPE. If we know someone is confirmed to have monkeypox, use PPE. And we just got a phone call yesterday for someone who was monkeypox positive and wanted to come to see the urgent care. Again, they didn't end up coming, but again, we want to make sure everyone is aware that PPE is needed. In terms of PPE, it's eye protection, it's an N95 mask, it's gloves, it's a gown. So please, please, please protect yourself, okay? Additionally, some of the other CDC recommendations to avoid the spread of monkeypox is take a break from activities that increase your risk of monkeypox. So avoid the things, close intimate contact. So avoid sexual venues, multiple anonymous sex partners, saunas, sex rooms, parties. Limit the number of sexual partners. They also recommend the use of condoms because it may protect your anus, mouth, penis, and vagina from exposure. However, remember, condoms alone may not prevent all exposure to monkeypox, since the rash can occur on other parts of the body. But most of the really painful lesions, or some of the painful lesions, have been noted in the perineal area. Okay. Additionally, wash your hands with soap and water or an alcohol-based sanitizer. You use an EPA-registered disinfectant, which includes bleach. Don't share utensils, drinking glasses, bedding, clothing, towels with anyone who has the virus. And then this is a really important part. Avoid contact with obviously soiled clothing, linens, or objects. So if you go somewhere and you see something is obviously soiled and you're in a public setting or even a private setting, don't touch it. I want to address some of the concerns that employees have already brought up to me, and we'll talk about more. Majority of them have really been regarding travel. So individuals are unlikely to get monkeypox from a plane seat or a hotel bed because of standard disinfecting procedures. That being said, if you see something obviously soiled on a plane or in a hotel, ask someone to clean it with a disinfecting wipe. You're unlikely to get monkeypox in shared spaces like schools, offices, or by trying on clothes in stores. A brief handshake is usually not enough to spread monkeypox. The risk of non-sexual transmission in household members is 0.6%. So even in household members where one person has been diagnosed with monkeypox, their household members have a 0.6% chance of getting monkeypox. So it is extremely, extremely low and unlikely to get monkeypox through a community setting. Again, if you have close intimate contact, that's not what we're talking about when we talk about community setting. Okay. So monkeypox vaccines are currently available, and they're really considered for three main categories of individuals. The first category is post-exposure prophylaxis. So it's an individual who had a documented exposure to someone with monkeypox. If a vaccine is administered within 4 days of exposure, it can prevent a monkeypox infection. So if you had close intimate contact with someone with monkeypox, or even then the vaccine, if given within the first 4 days, can prevent an infection. If it's given within 4 to 12 days of exposure, it may reduce the symptoms but not prevent the infection. The second category is what's known as expanded post-exposure prophylaxis, or PEP++. These are individuals that are at high risk for exposure, but don't have a confirmed exposure. So these are gay or bisexual men or transgender individuals who've had multiple or anonymous sex partners in the last 14 days, and they've engaged in survival and or transactional sex. So this is the main category. So these first two categories are who the vaccine is really available for right now. The vaccines, we only have a limited quantity. The federal government is ordering more vaccine, but until we get it, it's being reserved for these two categories. So it's for individuals who've had a known exposure that's moderate to high risk, so we're giving the vaccine to them, and it's also for those that are at an extremely high risk, so those that are gay or bisexual men, transgender individuals who've had multiple or anonymous sex partners in the last 14 days. The third category that vaccines are going to be available is for occupational exposure. So these are employees of a sexual clinic or a lab that's testing for monkeypox. Due to the limited availability of a vaccine, these individuals are being put on hold. Once health departments get their more allocation of the vaccine, it'll be spread or it'll be given to that population. So kind of similar to COVID, where healthcare workers got it, or healthcare workers, and then older individuals, and then the general public. So that's kind of where we are with that. So again, there's two vaccines that are currently being used. So the Enos is the one that's being given for monkeypox, and it's been approved by the FDA for monkeypox. We do have another vaccine that's the ACAM 2000, which has been approved for smallpox, and it has more contraindication. We're really using the first one for the most part. In terms of how well the effectiveness of the vaccine, we really have no data, because this is really the biggest outbreak we've seen. So so we'll get more of that information probably in the months to come. In terms of the current criteria for the vaccine, it's really for gay, bisexual men or transgender. You've had multiple anonymous sex partners in the last 14 days, or you've had a high-risk exposure. Initially, when the health department looked at it, they also felt individuals that were on HIV PrEP and gonorrhea and syphilis in the last 12 months should be considered. They're putting those two categories on hold just due to the limited number of vaccines, but it should open up as vaccines become more available. I think we had 300,000 vaccines to begin with, and we're ordering over 1 million more. So they should hopefully become available. When you read a lot of the articles, a lot of the vaccines have already been allocated. Treatment. So there's no treatment specific for monkeypox. Monkeypox is genetically similar to smallpox, and we have treatment for smallpox. So the smallpox treatment is being used for monkeypox. The treatment's known as TPOXX for short, and it's recommended in individuals who are likely to get severely ill or have a weakened immune system. Since this medication is approved for smallpox and not monkeypox, it's considered investigational. And so it's actually been very difficult for certain patients to get the treatment. The federal government has taken steps to make it a lot easier. I suspect it's going to get even more, it's going to get even easier in the coming months, just because we want to try to prevent the spread. So there is treatment available. It's really indicated for those with severe disease, so those that have hemorrhagic disease, multiple confluent lesions, they're septic or have a severe infection, they have brain findings or what's known as encephalitis, so those that require hospitalization. In terms of hospitalization, most hospitalizations are really due to pain rather than severe disease. It's also indicated for those that are immunocompromised, those with underlying skin conditions, the pediatric population, especially those 8 years or less, and then pregnant or breastfeeding women. So I will take a break. I've been speaking for a little over half an hour, and I'll open it up for questions.
I do have a couple of questions in the chat room, Dr. Shaw. The first one is, how long will this virus live on clothes, and can you get this from trying on clothes at the department store?
So in terms of trying on clothes, it's very, very unlikely. So even when there's household members with someone who's living with monkeypox, the transmission rates are very, very low. The virus can last, I think, for approximately 2 weeks, but transmission through that surface is very low. So that's why the recommendation is if it's obviously soiled, don't touch it. And then otherwise, it's very, very unlikely that you can get it through those modes of transmission.
Thank you, Dr. Shaw. The next question that I have is, if you have been vaccinated for smallpox, would you need another?
I'd have to look at that. I don't know how long the vaccination lasts for. So I don't want to speak without knowing for sure. So I would have to defer that, and I'll look it up and I'll try to send it out when I find the answer.
Those were the only two questions I had in the chat box, and I do not see any questions in the Q&A. If you do have any further questions, by all means, please add it to the chat box and we will respond to them. You may also send personal or intimate questions to the employeehealth@regalmed.com email box if you have personal questions that you would like to have. Again, that is employeehealth@regalmed.com. Another question that came in, what is our first workflow protocol for patients coming to our urgent cares?
So, pretty similar to COVID, if we identify these patients, we want to put them in a room, we want to use PPE. The protocol is being reviewed by the operations team, and we're about to implement it. So again, we have a written protocol, and we're just in the process of operationalizing it. So everyone on this call should hear about it if they're in the Lakeside clinical setting pretty soon.
Thank you. And for how long does the current vaccine protect you?
Again, I don't know the protection. Again, the problem with the vaccine is there's no clinical data on it. And so, or actually that's for the treatment. But again, I don't know. I'll have to look in terms of how long the current vaccine will protect you, and if you've had vaccination for smallpox previously, if you still have protection.
Thank you. Another question in regards to the protocol for patients coming in. For the time being, unsuspected cases, should we have them wait in the cars?
Again, I think we need to talk about it with the operations team. I don't want to make operational decisions. So again, it's something that we will, again, talk to your operations team about it. I'm here to kind of just present the medical stuff right now.
Thank you. Where do you direct the patient locally if a person has been exposed or has suspicion of monkeypox for treatment and or vaccine?
Department of Public Health. So all vaccines are given through the Department of Public Health, especially because there's a limited number. So again, if you're interested in getting it, go there. Go to the LA Department of Public Health website as well. They have a Monkeypox section. If you want to register for the vaccine, so majority of the vaccines have been allocated, but they have wait lists to get on if you want the vaccine. And the vaccine's indicated for 18 and above at this time.
Thank you. The next question is, what is the age of the patient who can get the vaccine?
It's 18 and above at this time.
Okay, that was the last question that was placed into the chat box. And again, there are no questions in the Q&A. If you have any further questions, by all means, please provide it to us, whether it's through the chat box and or if you'd like, you may send it to employeehealth@regalmed.com.
So I'll also just end on two things. Again, the general public's risk is exceedingly low, especially in a public setting. I know we've gotten a lot of questions about travel, clothing, things like that. So that is very, very low. My advice to everyone is don't touch anything that's obviously soiled. If someone has a rash, don't touch the rash. Try to keep a safe distance. If you do have to do something, touch a rash, use personal protective equipment. So again, these are my recommendations. The risk is relatively low. Remember, we're talking about 800 cases in California, but again, we really want to have a high index of suspicion, be really aware, test. I'd rather test more than less, and really the goal is to prevent the spread into the general public and to have this disease become endemic in the United States.
Thank you, Dr. Shaw. I do have one more question that came in. What should a child under the age of 18 do if they are directly exposed?
Again, I would defer to the Department of Public Health. Again, there is treatment, and the treatment can be given in that age group. Remember, the majority of cases of monkeypox are mild and self-limited. The majority of admissions due to monkeypox are really for pain control. The treatment works pretty well, and that's anecdotal from when you hear individuals with it, that it helped the pain and helped those lesions get better.
Thank you. Another question, should the testing be done in the clinic or in the health department?
I think it can be done whichever way is most expeditious. Again, we want to make sure that if someone's there, we can do it. Again, you can call the Department of Public Health if you need guidance in terms of a patient. But again, we want to make sure we diagnose every single case. And we do know we have personal protective equipment to protect ourselves. So again, we want to make sure, as long as it gets done, but again, we want to do it as expeditiously as possible. And then the other thing is if you have a presumed case or you're concerned about it, those individuals should be placed on home isolation because we don't want them to spread it to other individuals until we get the test results back.
One more question came in. Are there any disinfecting differences for monkeypox as opposed to other viruses?
Again, it's the same disinfecting procedure, which makes it easier. And so it's all FDA approved disinfecting agents is what we use. And so, yes, so it's the same, which is good.
And I do have another question. It says, how long for the results from the clinic or the health department in regards to getting someone tested?
From what I've read, it's 2 to 3 days. I haven't ordered it myself or haven't been involved in anyone that's ordered it. And so that's what I've heard, but I can't confirm that. Quest is saying 2 to 3 days. But again, it really depends on volume, kind of similar to what we saw with COVID. So again, we're hoping 2 to 3 days.
Another question is, how long should we close exam rooms if patients get swabbed?
And so that, I think we're going to probably follow something similar. Again, we haven't finalized that. I've sent it to the operations team. I think my recommendation was 4 hours and then a deep clean, which includes all the surfaces as well. But again, that hasn't been confirmed yet, so please contact your operations team to make sure once that's been, once my recommendations have been operationalized.
Okay, that was the last question that I see in the chat box. Again, if you have any further questions, please feel free to add it to the chat box and or send it to employeehealth@regalmed.com.
Thank you all for attending. I'm a resource for you guys. And please be safe. Thank you all.